And I'm going to go over a number of things here that I think might be highly relevant. We've been hearing a lot about dramatic changes in the healthcare system. And I have a question. How many of you here are healthcare providers? Okay. How many of you are administrators? Okay, great. So good, a nice mix. How many of you are both? All right. And how many of you work with mental illness, including substance abuse? And how many of you work with medical illness? How many of you work with the whole patient? Good. That's why you're here. And we should all be working with the whole patient. And that's something that's happening is we're removing silos. The whole system is moving towards, not you or us, but everything has to move towards removing silos. Because we cannot afford to have a case manager for every mental health condition and every medical condition. And that's something that's happened over time. And that's changing. And so today, what I'm going to be talking to you about is a lean process. Lean meaning it's very highly effective and not that costly, really, if you look at what we're treating here. And that has been proven. And it's basically what we call collaborative care. It's integrated care. And when I present this today, what I want you to be thinking about is not which conditions we treat. And I'm going to be talking about diabetes. I'm going to be talking about major depression. We're going to talk about anxiety disorders because we treat anxiety disorders as well. We talk about cardiovascular disease, and we treat all of those. Our nurse case managers treat the A, B, C, D. A1C, B, blood pressure, C, cholesterol, and D, depression. And we get significantly robust results in all of those, and I have the data to prove it. But we've also shown this in clinical trials, but we're also disseminating this now in 20 different organizations around the country and starting to get some early data results that are very, very compelling. And I'll show you some of those at the end here. So when we think about this, when you are listening to what I'm talking about, you may not be ready to just target diabetes or just hypertension or LDLs, but you may be thinking more about alcohol abuse or opiate dependence, and that's okay. It doesn't matter. This is kind of a plug-and-play system. It's not about the conditions. The patients that come to us, right, they come with a number of chronic conditions. It's a mishmash of things. We have created silos. We've created national institutes of every organ. We've created specialty departments, right? And we've got to start removing those because that's not what's standing in front of us when a person comes in suffering. We have to start to treat the whole patient. And this is an effort towards that. But it's a very robust and tested way of doing this. And I'm going to show you all the elements. Just as a preview, some of the elements are going to be measurement-based care, treat to target. How many of you have heard of treat to target? Good. Treat to target, collaborative care, systematic case review, population management. These are all the things that we've woven together into this program that I'm going to be presenting today. All right, so the final thing I want to say before I get started, we just did a training in Seattle, a national training about a month ago, and at the end of our 2-day training, one of the exercises we have, all the teams get together that come from different organizations, and we say, okay, we're giving you $150,000. So money isn't a problem because that's the number one thing that everyone says is a challenge is resources. So let's get that out of the way. You have 2 weeks. 2 weeks from today, you have to start disseminating this in your organization. What are the barriers? What are the local barriers to disseminating this? So what I want you to do as you're listening to what I'm talking about, because next week I'm going to New York and we're training up 17 hospitals. We're about 6 months into a contract doing this. Last week I was in Minnesota. We were training up 8 states in this, and it's the same struggles. Every organization is bringing up the same issues over and over again, and these are surmountable. And you can do this in your organization as well, but it takes a bit of a shift of thinking and buy-in from your organization. All right. Just as a disclosure, I have a company called SamePage, which creates patient engagement and behavior change tools. I want to introduce you to, and I'm going to be a little bit of a wanderer. I already checked with the videographer there, Mike, and he said that I can wander. So we have a team that developed this. I'm really glad to have been part of this team for about 15 years, but the team started long before I was part of it. Wayne Caton, and I'm going to see if this pointer works. No, yeah, sort of, not really. But Wayne Caton, Elizabeth Lynn, Michael Von Korff were the ones that started this about 25 years ago, collaborative care management in primary care. So how do we understand, how do we treat chronic conditions, and, including depression and anxiety in primary care settings? And this is built on that whole legacy of work, the foundation, many, many RCT grants over time, and now disseminating this around the country. So I'm a psychiatrist. I used to be a family doctor, and I've been a researcher for about 15 to 17 years, and I've been part of this team. And we've brought in sort of a diabetes component. I work in a diabetes care center. That's where I do all my clinical work as a psychiatrist. So really understanding how individuals with diabetes manifest mental health conditions. Bipolar disorder. Just yesterday I was in my clinic, had a patient with bipolar disorder, social phobia, anxiety, substance. I see a lot of substance abuse as well in patients with diabetes. I'm also the director of Training Exchange, which is one of the dissemination centers at the University of Washington that is implementing this. So let's start with the problem. Mr. T, he's a 54-year-old shipyard worker on disability for chronic severe depression. He has uncontrolled type 2 diabetes. And for those of you that don't work in the medical setting, the A1C is hemoglobin A1C, and 9.7% is quite high. Normal physiological range is 4 to 6%. We try to get below 7%. There's varying degrees of, there's some, ADA has one number and the endocrinologists have another number. But the idea is that we want, if people are over 8%, that's an indicator that something's not going right, and we have to start getting that number down. So 9.7% is quite high, and that's a 3-monthly test of blood sugars. So it doesn't lie. You can't fake it. You can't write it in. It's just like, here's what I've done for the last 3 months. Here's what my numbers are. Hypertension, 153/94, so he's got high blood pressure. He has hyperlipidemia. And obesity, he smokes a pack and a half per day. He has sleep apnea. He's on CPAP. And the CPAP he is actually using, and he's just had it tested. So despite that, he just still has fatigue, and I'm going to tell you about that in a moment. He has hypothyroidism and gout, and actually kind of surprising that he's not on more medications than this, but he's been on venlafaxine as well for his depression, and it ain't working. It gets worse, though. There's this ongoing fatigue in the context of this recurrent depression, and sure enough, when you check a PHQ-9, he's got severe major depression. It's past moderate into the severe range, and he's just not doing well. And so, as a result, everything else, if we look back at this slide, it's no wonder. And one of the endocrinologists that I work with, Earl Hirsch, in my clinic, when he sends me a patient, often in the recommendation line or the treatment plan line, he says, I can't do anything else for this patient from an endocrinologist standpoint, from a diabetes standpoint. He writes, I can't do anything else for this patient until we treat this person's depression. Does that make sense? How many of you kind of get that? And how many of you have patients that you see with diabetes that are depressed? It's very, very prevalent. In fact, having diabetes, you're at twice the risk of having major depression as people that don't have diabetes. So, at any given time, 30 to 40% of patients with diabetes in your clinics are going to have significant depressive symptoms. All right. So, I've been giving talks on depression and diabetes for years, and my colleague Earl Hirsch that I just told you about, he has his ICD-9 checklist of diabetes. I have my DSM-5 checklist of depression symptoms. And like I said, the patient's standing there, and they have neither diabetes nor depression. What they really have is, and I call it diapression. I coined that term a few years ago giving these talks, and I realized, it's very different after being in the trenches for 16 years treating these individuals that are struggling and suffering. There's all kinds of issues like smoking, obesity, physical inactivity, non-adherence, feeling also the judgment, self-judgment about I'm not doing well, and they're kind of confused about why their numbers aren't better. And it can lead to poor patient-provider relationships and so on. And so I wrote an article in Clinical Diabetes about diapression, and I have a case there about a guy named Daryl, who you can look at all the different ways that depression manifests in someone with diabetes. But the real problem is not Mr. T or Daryl or any other patient that they have complex comorbidities. That's not the real problem. The real problem is this. And I'm going to ask you this question. I'm going to get you to raise your hand. On average, patients with serious mental illness can expect to die how many years earlier than the matched controls in the general population? Is it 1 year? Is it 3 years? Is it 9 years? Okay, you guys are good. 12 years? Okay, who says 25 years? Yeah, you guys are right. It is 25 years. This is shown in these data here from the CDC. People with serious mental illness die 25 years earlier than people without serious mental illness. And many of you knew that. But here's the next question. In patients with serious mental illness, the main cause of premature death is, and I want to see hands, is it cancer? Is it heart disease? Is it suicide? Is it cerebrovascular disease? Or is it diabetes? Okay. So a little bit of a trick question, because I've been talking about diabetes and so on. And it's good you didn't say suicide, but the answer is heart disease. But it kind of makes sense with what you said, because diabetes is one of the biggest risk factors for having a cardiac event, right? If you have diabetes that's not well regulated, your risk of having a cardiac event is double that of someone who has it well regulated, someone who has diabetes but in good control. And you can't see this below here very well, but this is cancer in the blue. So it's heart disease, then cancer, and then there's a big part of the pie that's other, but suicide is just 1%. So the thing that's killing people is the medical problems, right? So therefore, we need to be thinking of the whole patient. We are not doing our job if we're just treating the mental illness. We have to be thinking of the whole patient, because a determinant of premature death is this lack of treatment of these medical conditions. Oops, what did I just do? Okay, there we go. And if you look at the CATIE trial was a trial looking at atypical antipsychotics and antipsychotics in a large sample. And if you look at that group, and those are the pie charts, and then at the bottom, I have data from the NHANES study, which was patients with diabetes in the nationally representative sample. So what you saw in the CATIE trial in people with serious mental illness, about a third of them had hypertension, and only a third of those had it treated. Whereas if you look at the NHANES data, similar, a third had hypertension, but 70% had it treated. And same with diabetes. I mean, this is about comparable, but again, 84%, if you look at the bottom right there, compared to 69% treated in patients with serious mental illness. And this is for dyslipidemia. 12% of people, of the 50% that have it, only 12% had it treated compared to half of them in the general population of patients with diabetes in the NHANES. We're entering the era of the multi-condition patient. So again, we can't just be treating one part of the person. We have to learn. When I talk to my residents and the fellows that I work with, I say, your generation, you're going to be treating multiple conditions. They work with me in the diabetes clinic, and they learn behavioral skills. They learn how to deal with not just the treating the depression, but also how do you treat non-adherence, how do you work with individuals around self-management, problem solving, and so on. So that's the key. We have 75 million people in this country with 2 or more chronic conditions. 90% of patients with diabetes have at least one other chronic condition. But this is another part that's really astounding. In a huge study, this is very impressive. This was a study that was done at Kaiser Permanente with millions of patients. That they looked at automated data, and they found patients with A1Cs that were very high. Remember, I told you 4 to 6% is physiologic, 8.5% is quite high. They had systolic blood pressures that were out of target and LDLs that were out of target. And when they asked the question, what proportion of these patients were out of target because of non-adherence, what do you think people said as far as treatment non-adherence? What proportion of these people had non-adherence? Who wants to say, just shout out a number? What percentage of these people were non-adherent? What's that? I'm hearing 75, I'm hearing 90. Yeah, exactly. And that's what I would think as well. And even when I thought about NHANES data and we look at naturalistic populations, but it's incredible actually. It's only about a quarter of the people have poor adherence, or the reason that these values were out of control was because of poor adherence. Actually, the majority had adequate adherence. However, what was happening was this concept of clinical inertia. How many of you heard that concept? Okay, so clinical inertia is not the non-adherence of the patient, it's the non-adherence of us, okay? It's the lack of treatment intensification. And it's not for any fault of ours, really. Our intent is good. We have good intentions, but we have a broken system. Our prevailing healthcare system can't keep up with people with multiple conditions. 15 minutes every 3 months isn't going to cut it. And that's what lack of treatment intensification is. That's what clinical inertia is. And that's why we can't move forward without a team-based approach. We can't move forward without care management and integrated care and removing the silos and trying to understand how do we treat the whole patient. And so I'm going to talk a little bit more about this, but I want to just for a moment also think about yourselves as clinicians, right? And yes, we always talk about the challenges with patients. You know, they don't collaborate with us, they aren't compliant, or the more PC word is non-adherent, or they don't manage their self-care or their self-management. They miss appointments, they're dissatisfied with care, they have a go-it-alone attitude or approach, they have poor self-care, and they have all this stress, anxiety, and depression. So I want you for a moment to be honest with yourselves. And we're going to put a mirror up to each and every one of us. And it's not about the patients. What about us, clinicians, if we're really honest? Hold the mirror up to ourselves here. How many of us are not good collaborators? We were raised in the cowboy kind of, I've got my caseload, I'm going to ram through my day of patients, and you know what? I have 4 people in the waiting room. I don't have time to call in this person and that person to get it done right. And that's, again, not any fault of our own. That's our training and that's our system. How many of us don't adhere to clinical guidelines or adhere to what we really know needs to be done? Either thinking about Maslow's hierarchy of needs, what does it really need to be done for this person today? Otherwise, it's a deal breaker and nothing else is going to change. But we're exhausted. We don't have the resources. So we're non-adherent as well. How many of us miss appointments? We're there. I showed up, but I'm not really listening. I'm glued to my EMR, and I'm not really listening to your story, patient. I'm sorry, because I'm a busy doctor. I'm just too busy, and I don't have any resources, and they're cutting everything, and I just can't help you much anymore. So I'm missing this appointment. I'm kind of only partly there. Or how much are we dissatisfied with care? The level of burnout these days is rampant. How many of us have a go-it-alone attitude or poor self-care? You know, we walk in flying from lunch with crumbs on our face, eating our sandwich, and we're telling people to slow down, take time to eat a proper meal. We're hollow. We've become hollow. We're not healers, we're hollow. You know, we don't mean to be, but our system has forced us to sort of rush from one thing to another, and we're just not making it. And that's why we have so much dissatisfaction and why we're stressed, constantly stressed and anxious, and often hate our jobs. So there has to be. And I'll tell you the solution. I've been doing this now in parallel. So in my clinic in the Diabetes Care Center, I do co-located care, which is fun. I drop in, and a few times a week. I'm there, and I talk to people between sessions and everything, or my colleagues. But I'm co-located. I just drop in. I serve all the depressed people in there. But it's not collaborative care. What I'm going to tell you about is something that's deeply, deeply satisfying as a healthcare provider. I've been doing this work in parallel with all these studies, and I'm doing it right now in Seattle. We've been rolling it out at a large center, what I'm going to show you today. And it's some of the most rewarding work because we're all working as a team and we're getting tremendous synergy. 1 + 1 = 3 or 5 or 7. It's just wonderful. So, what am I talking about? I'm talking about collaborative care. You can't see all these definitions here, but this is from ahrq.gov, and it's supposed to be a tree. This is the actual diagram. If you can see it a bit, there is a tree of definitions here. And like behavioral health care, shared care in Canada, it's called shared care, collaborative care, and so on. You all heard of this, integrated care. Now, right in the middle there is my favorite definition. I'll give you, I put it in a tree-like fashion as well to sort of stick with the theme here. A team with a shared mission using improved clinical systems to deliver improved care to a patient population supported by operational and financial systems. Such care is continuously evaluated through improvement processes and effectiveness measurement. It's measurement-based, it's a team approach, it considers the operational and financial systems, and it works. I'm going to show you how it works in a moment. But let's just take a look at who the players are. So there's the patient in the middle, and instead of the traditional primary care provider to patient, that still goes on. That still goes on. We're not replacing that. But in parallel, we have a case manager, a nurse case manager usually, but I've also conducted trials like the PEARLS program, which we had social workers go into homes of people with depression and 5 chronic medical conditions. And then we have a weekly case review, and I'm going to show you a video in a little bit about how that happens. But that's where we have a psychiatrist and an internist reviewing every case. In 2 hours, and I do this every Thursday from 8:30 to 10:30, so I know that I'm not lying or giving you a story here because we do it. Sometimes we finish in an hour and a half. How many want to guess how many cases we can review in an hour and a half? Throw out a number. 10. The other number. Huh? 2, 5, 40 to 60. 40 to 60 cases. And I'm going to show you how that works. And we've been doing it now for 7 or 8 years since we started this. I've done it previously. I've been doing this for 15 years. There's a method. You have to be organized. There's a way of presenting. You have to have the data in front of you. And you present all the cases. You come up with an action sheet. It's very lean. And you don't miss anything. And you still have the best care, the patient, but what you do is you distill all the important points so that in a systematic case review, you go over the key points. And you come out with an action list, and everybody on the team knows exactly what the 2 or 3 things that have to happen with that patient in the next week, not the next 3 months, are. And then you meet again a week later for 2 hours, and you review 40 to 60 cases. So if that sounds impossible, I'm telling you, we're doing it all around the country. And I'm personally reviewing 6 case managers every week. And in 2 hours, we review 40 to 60 cases. And they have depression, they have heart disease, they have diabetes, and I'm going to show you some compelling results later about how well it works. So you can read more about this at teamcarehealth.org. That's our website at the University of Washington. You have all the free materials you want there. You just download anything you want. There's piles, too many. You don't want to print them all. There's so many materials there for you to do this. Okay? There's our manuals and everything. And you can start to look at them and see how you're going to deploy this. There are training parts that we offer. Of course, at the university, we do our national training once or twice a year, and then we also work around the country doing this. So here are some of our partners doing variations of team care, including in Washington State and you can see in other places all around the country, plus New York on the bottom right there, Texas, and there you go. And this is a map of a version of this that's being conducted right now in 8 states. It's called COMPASS, and it's through the CMS. It's a Health Innovation Grant, $18 million grant to deploy this as well in 8 different states. All right, so who are we talking about when we talk about the patient? And again, I want to say to you, this is not about who we treated. This is about the components. So you can add here substance abuse. You can add here, opiate dependence. You can add here anxiety on a GAD-7 over 10 or whatever score you want. You can add here, if there's a way to measure it and a way to put in individuals, say with psychosis, or, and if you have a way to kind of measure, you have to have measurement-based care over time, then you can add those individuals as well. But we're doing it with these four parameters. PHQ-9 over 10, which means major depression, that's at the bottom, and they have to have poor disease control in their diabetes or their coronary artery disease. They have to have A1Cs over 8.5%, blood pressures over 140 over 90, and LDLs over 130. So that's who we targeted. So if you take out the depression, these are highly, highly complex patients. These are patients that are not doing well medically. But then we weren't comfortable with that. We wanted to make it even harder, so we added the depression in, right? And then, of course, they have all kinds of other psychosocial issues as well. Our goals were to improve depression care through behavioral activation, problem-solving, antidepressants, improve medical disease control, A1C, hypertension, LDLs, and improve self-care through diet, exercise, cessation of smoking, very important, and glucose monitoring. Remember the heart disease connection, cessation of smoking. People with mental illness are at higher risk for dying of heart disease, and one of the pathways is through smoking. So our program goals were to reduce A1C, B blood pressure, C cholesterol, and D depression. We used collaborative depression care and the chronic care model. How many of you have heard of the chronic care model? Ed Wagner's chronic care model, he's in Seattle, and he conducted some of the first studies like this, looking at using problem solving, using behavioral activation, using case management to treat people with multiple conditions. I was lucky to get a chance to work with him on those studies as well, one of them being the Pearl study. The core components. First of all, we want to distill things into behavioral goals and really, but also understand the goals from the patient's perspective. I was talking to Racy this morning, and we were talking about how to set goals for patients and how to, this was at lunch, and we were talking about how to set goals, from the patient's perspective. How are these meaningful goals to them? And of course, that ties into motivational enhancement, motivational interviewing, but then also we want to support self-care. We want to support self-care, and there's many, many ways that we can do this. In our case, we gave them materials and books and videos on depression. We had a patient manual. We had all kinds of educational strategies, motivational interviewing, medi-sets. We simplified medication regimens. We had $4 generics. We used, formularies as much as we could, and every system has to figure out how to do this in their own way. We brokered deals with organizations to get discounts, deep discounts on blood pressure monitors, or got patients to go to the pharmacy or go to the fire station to get their blood pressures monitored. Because guess what? White coat hypertension really does exist. When people come to clinics, they're often rushing. They just had 3 cups of coffee, and a blood pressure cuff is slapped on their arm, and it's not a really good measure. You really need a lot of intervening measures to really follow blood pressure. People had functioning glucometers, and we'd make sure they had them. And then down here, for some people that we wanted to get physically active, we'd give them a pedometer as well. Or the hospital would figure out how to get a deal on pedometers. Care managers use motivational interviewing and enhancement, problem solving, behavioral activation. And I'm going to talk a little bit about those. How many of you use problem solving, the problem solving method? Okay, so problem solving is something that it's a 7-step process where you're starting at the bottom, you help to find the problem, you recognize and identify the problem, then you try to find a clear goal or selecting and defining the problem, generating solutions for a goal, and then there's a process of brainstorming. So this is the key to problem solving. It's actually a method. If you go to pearlsprogram.org, we have a whole manual on it. We teach it. And basically, the key here is you disconnect the judging. When a person's depressed, they can't solve problems because they can't come up with solutions. So what you tell them is say, we're going to do the pros and cons of each of your solutions later, but I want you to think of all the solutions that you can come up with, and then we're going to judge these and rate them, and then you're going to pick one. And that method, we found that 3 times as many people went into remission from depression. These are people with 5 chronic medical conditions. We did 6 sessions of problem solving with patients, and 3 times as many went into remission as in usual care. There's meta-analyses of problem solving for depression. It's been found to be as effective as antidepressant medications for moderate depression. And also in the diabetes world, problem solving has been used to lower A1Cs by about 0.5 to 0.7%. So it's a really important method to understand. It's very, very simple to learn. The other thing we use is behavioral activation. How many of you use behavioral activation? Every time I see a patient in the diabetes care center, whether I'm prescribing medications or not, that's one thing I might do. I might titrate their medication, but then I'm going, are you exercising? Are you connected with your family, your friends? Are you engaging in pleasant activities scheduling? I just drew this yesterday on a piece of paper and handed it to a patient. I draw it almost every week for a patient. When we feel bad, we do less. We don't answer the phone, we put the cover over our heads, and then we spiral downwards into inactivity. And part of our job as providers is helping people to break that cycle. It's a very bad cycle. And then, how many of you know about decisional balance? Okay, not many. This is very cool. Go to Google, look up decisional balance. It's really cool. There's even some videos there. The motivational interviewing people have brought this in, but this has been used since 1950s, 1960s. Janice and Mann came up with this, and I use it all the time in my clinic, but we use it in team care as well. And the cool thing is, when we're doing team care now, I'm the behavioral guy, the psychiatrist, but the internist is saying, shouldn't we do decisional balance? We want to start this person on insulin. So it doesn't matter whether you're starting them on insulin or you're getting them to go to rehab. And by the way, decisional balance has been used for years in addictions. So if you look up addictions, decisional balance, you'll find a lot of literature on this. And so let's say a guy wants to quit smoking. I'll show you how this works. So let's say I say to the guy, you want to quit smoking. So what are some of the benefits for you to quit smoking? Well, I'll cough less, my wife will be happy, it's socially acceptable, and my wounds will heal. I have diabetes, my wounds will heal much faster. And then the usual thing is saying, well, if you don't quit, if you keep doing what you're doing, smoking a pack a day, what are the downsides of that? Well, I'll have a higher risk of cancer, I'll have poorer health, and like I said, my wounds won't heal. Okay. And that's usually where we leave it. And we usually say, you should quit because your wounds won't heal, and you should quit because of your poorer health, and so on and so forth. And if I go to Wikipedia and I look up the reasons why I should quit smoking, I'll find the same things. No, the real answer, the real magic of this tool, and it takes 5 to 10 minutes to do this with your patients, the real magic is these are the concordant cells, the ones that are kind of obvious. The magic is in these cells here, the discordant cells. This is where the magic happens. This is the idiosyncrasies of that person in front of you. Nobody's going to have the same answers here. And when I ask that person, what are the pros for you if you don't quit? Like if you keep smoking, what are the advantages to you? And they say, well, I can't deal with stress if I don't have a cigarette to relax. Or in the morning, I can't think clearly. It's hard. And it keeps the weight off. I have a whole closet full of pants that are like 4 sizes bigger than this. And the thought of that, I'm depressed now. You want to see me depressed? If I start gaining weight again, that kind of thing. And guess what? Studies have been done, since we're talking about smoking. Why do people smoke? I mean, it really regulates affect. And people have shown that in studies, if you get people to quit smoking, sometimes they become depressed because they've been treating their depression with cigarette smoking. So that's just an aside. Or you say to the person, what are the downsides or the costs of changing for you? Well, like I said, or changing. If you quit smoking, what are the costs? I'm going to gain weight, but more importantly, I'm going to lose my friends. The only friends I have at work are the people I smoke with on the stairwell. And, that's the only thing that gets me up in the morning to go to work is hanging out with my buds. That kind of thing. So you get what I'm saying. So now the goal is, that's where the focus needs to be, on those discordant cells. So that's a huge part of this. And it's a tool to just streamline this whole focus on motivational enhancement and interviewing. We monitor progress. Another key component here is data is your friend. You cannot do this unless you have the data regularly. You are not doing collaborative care. You are not managing people unless you're paying attention to data. So this kind of thing of throwing a medication at someone and having them come back in 3 to 5 months, that's the prevailing healthcare system, and that's why we're not getting outcomes. That doesn't work. We need to get data. So this is an example of our weekly case summary. This isn't exactly what it looks like. I have in my pack upstairs and the actual one we use, and we actually have 45 cases each line. I don't wear glasses yet, but I'm holding it out like this to kind of read the lines. But we have everybody's number. So each one of these rows is a patient. And remember, yes, there's tons of data you could bring to a case review, and you could go over 2 patients, or you could just distill the measurements. And you could always do a deep dive into the other facts, but you need to present the data. So you want to present so what you can see there at the top is enrollment date, what's their PHQ at baseline and now, what's their blood pressure at baseline and now, what's their hemoglobin A1C at baseline and now, and what's their LDL at baseline and now. And what the program does is it automatically, or you can just do this manually, just put a little asterisk. If they're not in target, put a little asterisk. And then you can sort the cases, you can sort each of those columns so that people with all 4 of those not in target are at the top. Start with those. Those are going to be the ones that need the most attention. And this is called population management. This is a case registry. If you don't have this in your weekly case review, which I'm going to talk about in a moment, you are not doing population management. People are going to fall through the cracks and they're not going to get better. So what do we have? We have A1C, blood pressure, cholesterol or LDL, and PHQ-9 scores. And you could have whatever other scores you want. You could have GAD-7s, you can have symptoms, any kind of other symptom scores, or weight for congestive heart failure, or if you had spirometry data for people with COPD, or urine tox screens, whatever you want. So now let's talk about treat to target. That's another important component of this. So frequent and consistent titration of our treatment. And it's based on this. Now you've got the measurement in place. Every week we're looking at numbers and we're titrating. We have relentless incremental increases. And as a team, we're all responsible and accountable. And if we don't increase to the next step, we have to document why not. If the following week we say, well, why didn't it happen? We document why it didn't, and we together as a team come up with a new plan about how to make this happen. And so we use algorithms, we use formularies, guideline level things. So for example, for depression, you might start with 20 of citalopram, increase by 10 milligram increments to 40. If partial response, then augment with bupropion or Wellbutrin. If no response, you can change it completely to full dose Wellbutrin as an example. And then I'm going to tell you about systematic case review. So look at the components. Identify goals, support self-care, monitor progress. That's using the case registry, using treat to target now that you've got the data at hand. And then this is probably the secret sauce here. This is the secret sauce, the systematic case review. So here's an example of what it looks like. This is a floor plan. Here's a table, and there's a psychiatrist on the bottom right. There's a PCP on the top right, and there are 2 case managers and a behavioral health person that might hover between case teams. Come in for maybe not every case review, but this is done once a week And every case is reviewed. And by the way, another key point here, and I'm going to maybe I'll repeat it more than once. You don't just review the people that are showing up. You don't just review the people that are not doing well. You review everybody on the caseload. Everybody. It takes 8 to 10 minutes to review a new patient. It takes 2 to 3 minutes to review a follow-up patient, and it takes about 30 seconds to 60 seconds to review someone who's almost in target on all things. They're doing well, but we're still waiting on a measure. And you review everybody on the caseload, because the people that aren't showing up might even need more of a discussion than the people that are showing up. There's lots of tricks. We do ambushes in clinics. We look on their medical records. Oh, they're going to be in a dermatology clinic, or they're going to the rheumatologist, and the case manager shows up in the waiting room. We get lots of phone numbers from them, and we figure out where they are. I know you guys know this. You do this all the time. But that's an important part of this. So I often hear people say, oh, we do huddles and we talk about the worst 3 or 4 cases. We're doing patient-centered medical home. That's fine. You're doing patient-centered medical home or something like it, but you're not addressing every patient. You need to address every single patient and the ones that aren't showing up. That's population-based management. And using that systematic case review sheet, you have all their numbers. Okay, when did they last show up? That would be another column. Oh, they haven't been in for 6 weeks. What are we going to do about this? Their A1C is 10%, their LDL is 150, and they're depressed, and we're not doing well. We're not serving this person well. How do we get them in contact? So I'm going to show you. Now, if you go to trainingexchange.org, you can see this video as well. And there are 3 of them on this. If you just go to Training Exchange, that's our training center, and you go to our programs on the top nav, and then you click Team Care, and then when you open the Team Care page, there's a registration thing, but at the top there's videos, and you have 3 snippets of videos, and then you just put your email in, and it opens it up for you, and I don't know for how long, but it's enough. They're 3 8-minute videos to just look at a case review.
I have a few thoughts. Can everybody hear me in the back?
Yeah.
Okay. So there's a medical professionals who have prescribed meds for him already. Are those 2 doctors his medical doctors?
Wonderful question. So that first figure I had of the triangle, there was a primary care provider, there's the patient in the middle, there's a case manager who has a lot of dialogue with the primary care provider. What you're seeing here is the once a week, 2 hours with independent, unrelated primary care provider and psychiatrists that are listening to the 50 cases. This is an 8-minute version of the new patient. And then they're going to follow up with a whole bunch of other cases, but they are not the doctors of this patient.
So I have a few more questions. So they're making recommendations.
Yeah.
The PCP is on board with this, that some other professionals are going to make recommendations to decrease dosage, or is that the role
PCP
of the...
makes the change. So everything that's just talked about in that, nothing happens unless the PCP makes the change. So all that we're doing is we're reviewing cases and going, the busy primary care provider with 4 people in the waiting room, you can't possibly do that. All we're doing is pointing out what things can be titrated and whatever, right? And you're getting sort of, psychiatrists and someone that can have another look at it. And then the PCP is making the changes if they agree it. And 90% of the time they agree with the change.
So the nurse is going to take that back to the PCP
They do.
and say these are the recommendations, and then the
They
PCP
do.
makes the final.
Yeah, that's a great question. So I was just on a conference call with New York this morning, and we were talking about how do we get. They were talking about how do we do this in our system, and they're enrolling. There's like 17 healthcare organizations. We're talking to 4 of them today, and we said provide good customer service too. You ask the docs, how do you want this information? Do you want me to email it to you? Do you want me to call you? Do you want me to catch you in the hall at your clinic? And then the docs are just going to love it, because all of a sudden you're taking on a big part of the complex patients. And you're providing the information where there was a review. The doc ultimately has a decision that they can always make a decision not to follow the advice.
Any pushback from the docs on that?
Yeah, rarely. So like I said, it's about 90%, 95%. I've been doing this for years with, just in the current place where we're working, 32 docs have sent us patients in the last year. Some of them send us repeat, 11 patients. And we probably had maybe, a handful of pushbacks. Or it'll be something like, I really know this patient well. I'd like this suggestion, but I don't want to do this maybe for another 3 or 4 months. But I like this, something like that. They want to postpone it.
You talk about an algorithm for prescribing antidepressants.
Yeah.
And you talk about the basic skills of problem solving, behavior activation, motivational interviewing. But do you talk about a frequency of treatment in terms of the therapy like twice a month, or what's the adequate treatment, and what's the amount? Are you treating in a 30-minute model, in an hour, and
okay,
the
yeah, great. So I was going to start getting into that. So it's a perfect segue. But basically, the nurse case managers spend, between 15 and 30 minutes weekly or every 2 weeks with these patients. Half of the visits are by phone, and half are in person. And so it's very lean, but it's diligent and regular. And so we've done the math on this. So when we did a clinical trial, there was about 10 phone contacts and 10 in-person contacts over a year. But what we've done more recently, we're disseminating this now, and patients stay in for about 16 weeks to 18 weeks, and then they're kind of graduated back to, quote-unquote usual care. And there's probably, about the same amount of contacts, maybe 8 to 10 by phone and 8 to 10 so it's roughly weekly or so. So, but about once every week. So let me kind of tell you a little bit more about that. So here's a case review model. This is where I was telling you that so here's me on the lower right, and the internist on the top, and then we have, there's me, the internist. You've got 6 case managers, and they're all working. They're already doing They're already doing case management in other programs, so they were trained up in this in a 2-day training, and they're doing up to 0.25 FTE, so 25% of their time doing this. And so they might have 4 to 6 patients on their caseload, and they come to this for 2 hours. And so, you could do it that way. You could have 2 people doing half-time FTE, whatever configuration you want. Once you get past 2 case managers, you want a manager of the case managers, because there's going to be maldistribution, like how many, and there's someone in the systematic case review that's listening and going, sometimes, there are competency issues, or you need a booster session in certain things as well. And then we have a pharmacist that joins us a lot of the time. This person works in the lipid clinic. And then we also have a diabetes educator, not there every week, but most of the weeks. So, but at the very least, you have the case managers, the psychiatrist, and the internist. And then, this is a very important member of the team here. This is a screen this is a floor plan. So this is a screen, just like this screen that the slides are on, but it's the EPIC chart, or whatever EMR you're using. And this system, we just pull up. So this person right here is the navigator. They're on the computer, and every patient that's being presented is up on the screen. So we can quickly look at the meds. We can quickly find out when was their last visit, what labs are they missing, and everything's done right there very quickly, very efficiently. By the way, let's say that case manager at the top is presenting. That case manager at the top is not going to be the scribe. Somebody else is the scribe. The person that's presenting their 4 or 5 cases never has to write anything down. They just present quickly, and somebody else is writing down on something called an action list, which is this here. So what you can see here is every patient, and you can change the size of those cells. It doesn't matter. On the right-hand side are a whole bunch of prompts. Did you check the formulary for better, behavioral activation, motivational strategies, disease self-management? Do they have a blood pressure cuff? Sort of a reminder. And at the end of the case review, every patient has their action steps for the next week written down here. We photocopy it. We're still old-fashioned, and we distribute the papers to everybody in the room, so that everybody knows who's about each other's patients. So if someone is away, a case manager's away, or between me and the internist, if I'm away, the internist can cover for me around antidepressants, because we're focusing on certain action steps. And the other really cool part of this, other than the first visit, when you're doing the follow-up visit, what we start with is the action sheet. So the nurse would present and say, last week, the 3 action steps were increase citalopram to 40 milligrams, start the DASH diet, and give the patient educational materials about starting insulin. I was able to do number 1 and number 2, but I talked to Dr. Jones, and he thought that we shouldn't start insulin for another month or 2, and that's it. And that's like not even 2 minutes. And there may be a few questions, and then we move on to the next case. And we're focusing on action every week. Does that make sense? And this is what it actually looks like in the real world. I've redacted any information. This is what it actually looks like. Zoloft, increased by 50 milligram increments. Diabetes education, give options to the behavioral intern. Diabetes education, increase citalopram. How much metformin is she taking? Find out. Is it 1,500 or 750? These things won't happen in usual care if you don't operationalize it. Okay, and then care coordination. So one full FTE case manager has 100 patients roughly, and at steady state, about 50 patients at any time. Because remember, we keep these patients for about 4 to 6 months. So in a year, they cover 100 patients, but at any given time, it's about 50 patients. The psychiatrists give about 2.5 hours of their time, the psychiatrist per week, and the internist 2.5 hours per week. So that's about 10 hours per month for each. And does it really work? So here's an example of Mr. T. You know, the venlafaxine wasn't working, so the team decided this is an actual case. You know, start citalopram, titrate up over 6 weeks. Then they added bupropion, and then they were doing ongoing problem solving, and they finally got his depression score, maybe for the first time in 5 to 7 years, down below 10. And he got better depression scores for the first time in a long time. Meanwhile, they also focused on diabetes education, addressing his emotional eating. They were able to finally start insulin. Everybody in that clinic has wanted to start insulin on this guy. Finally, they were able to start it because they had the infrastructure to do it. They talked about psychological insulin resistance. How many of you know about psychological insulin resistance? It's very cool. Look it up. It's very cool. Read some articles about it. It's all the misattributions that patients have and preconceived ideas people have about insulin and how you work with a patient around their ambivalence about starting insulin. So it's insulin resistance, but the psychological part of it, right? So then he got nutritional counseling. He started on insulin and so on, and you can see the results. We published this in the New England Journal of Medicine 3 years ago after doing a clinical trial in 14 clinics. We were able to change, with 1 case manager per patient, A1C, blood pressure, LDL, and SCL. SCL is symptom checklist. It's a depression measure. So we were able to affect all 4 things, not just one of them or 2 of them. On the whole, every one of the whole population got better in those regards. So if you look at this team care program, so I versus C is intervention versus control. This SCL difference was 0.4. The effect size is 0.65, which is a difference between the means divided by the standard deviation. 0.65 is huge. Hemoglobin A1C was about 0.6% difference for the whole population after getting this treatment. Meanwhile, their systolic blood pressures dropped by 5.1 and their LDLs dropped by about 7. And if you look at other studies, so in comparison, if you look at meta-analyses, 37 collaborative care trials of depression, that first row, the effect size was only 0.25, it was not very strong. If you look at 66 diabetes care trials, it only had just focusing on just the diabetes, they were only able to get a change of 0.4, and we're managing 4 factors, and we were able to get better than that. And then 44 trials looking at systolic blood pressure, it's similar, and there weren't similar trials looking at LDL cholesterol, so we didn't report that here. We also focus on the Sheehan and the HUDAS, or disability measures, so there's less disability. There's increased quality of life, which is really important, thinking about recovery. It's not just about the numbers. It's about quality of life. It's about changing the medications. This is how we do it. It's just dogged, tenacious, treat-to-target approach to changing medications. So OH is oral hypoglycemics, IH is insulin, the second one, AH is antihypertensives, LL is lipid-lowering agents, AD is antidepressants. In each case, the intervention was greater than usual care. And satisfaction with depression care, looking at 6 months and 12 months, was significantly higher, 87 and 90%. in the intervention group. Same with diabetes and coronary heart disease care. And then finally, after 2 years, we saved $600 per patient. And if you look at fee-for-service, where you can bill $54 per visit for a nurse around diabetes care, it's about $1,100. So think triple aim, better outcomes, robust, better outcomes, increased quality of care and satisfaction, and cost savings. Isn't that what the Holy Grail is?
I'm not a clinician.
You're a grant writer.
I'm a grant writer.
Awesome.
So my perspective is very different, and
No,
my knowledge is way down. But how did you measure, because that's my forte is measurement.
Sure.
How did you measure quality of life?
We used probably the SF36.
Okay.
We've used various quality of life measures. We used the FACT-G in another collaborative care trial. We've used the SF36. We might have even used parts of the HUDAS.
Okay, so
yeah.
they were all measurement tools like that.
Oh,
They were-
yeah, very
okay.
robust.
Okay,
Yeah.
thank you.
Okay, sure. So I'll just finish up here, and then I'm going to leave it for questions. So we save money. I want to show you this. I just presented this at the American Medical Group Association in Phoenix. These are results from 1-year implementation at a hospital in Seattle, or a fee-for-service center that has 200,000 patients. And we've been doing this for a year. And there's something called the bundled benchmark. If you look at the if you look at patients with diabetes, in the NHANES study, half of people get their A1Cs in control, half the people get their blood pressures in control, half the people get their LDLs in control. But if you ask what proportion of those patients in a longitudinal study of patients with diabetes get all three in target, it's 18%. There was just a recent article that came out from the CDC. And we used slightly different cut points. We used a systolic blood pressure of 140, A1C of 8, and an LDL of 100. When the patients started in our program, you can see here the ones that graduated, they were there for 16 weeks. 16% of them had all three of those in target, those three things, systolic blood pressure, A1C, and LDL. And these were the most depressed patients. At the end of 16 weeks, 70% had all three of those in target. And that's unheard of. Even the best hospitals, in fact, the benchmark for this hospital, I don't have the slide here, was 38%. The best they could do with the whole population of patients with diabetes, not the depressed ones, was 38%. And we're hitting 70% with the ones that are most depressed, that have major depression. So if you're thinking about something like this, if you're thinking about achieving level 2 or level 3 PCMH, NCQA accreditation, which I know a lot of people are, you need 2 medical conditions and 1 behavioral condition. So this program allows you to meet must-pass components for NCQA accreditation. And I really want to stop because I think we're running out of time, and I want to make sure we have time for questions. And I want to hear, as you were thinking about this, what would be the barriers in your organization to implement this? Or is this something that you could do? So I want to thank you. And I'll open it up for questions. Yes. And is someone going to... Oh, there's a question there. Great, thanks.
Just a quick question. It all sounds really wonderful. I know that there's a lot of things that we can do better in doing healthcare, mental health care, and AOD care in an integrated way. 100% on board with that. Well, I think one of the things, I'm one of those administrative types that look at the bottom line of trying to get the people to do the job. And my question is from a county system of care, we're struggling just to get the staff to see our patients, let alone to set it up in what you're talking about from what seems like from a private sector, nonprofit or for-profit kind of a program, that they can do it. It's not a problem for them. From a county sector, though, it's very difficult trying to put together a team like this that can do these reviews, do this kind of follow-up, do this kind of care on a weekly, monthly, yearly basis, and find these outcomes. So, just a question: have you worked with counties in regards to...
So we're working with CHPW, which is Community Health Plan in Washington. We're working with 17 healthcare organizations in New York State, and I'm not saying that it's going to be as easy in county hospitals. We're working with dual eligibles. There's a lot of, you have to find people, they're homeless, and you have to figure out how to get hold of them, and you have to, everybody's got very little time, but, if you can find, 2 hours and start out small, I would say don't implement it for 400 patients. What if you just picked 2 case managers, got them trained up, and just started a small program like this and figured it out in your setting? All politics is local, all challenges are local. You're going to have to figure out in your setting how could you do this, and start to blend in some systemized review of those patients that have these things that you can measure and make changes. And start small and then grow it from there.
Just follow up in regards to psychiatric support. We have, we're down a couple of psychiatrists, and like I say, trying to follow up with a inpatient unit and outpatient services. Have you worked with, for instance, locum tenens in dealing with something like that?
Absolutely. So everyone heard that. So locum tenens, or you could use telemedicine. Have a psychiatrist from some other part of the state doing it. Once you get out state, then you have to worry about licensure issues. But if they were within the same state, just do it by telemedicine. And make sure the internist and the psychiatrist are in the room at the same time, whether it's virtually or not. Ideally, it's done face-to-face for the first few months until you really gel and get this going. But you can use locum tenens. Remember, it's 2.5 hours a week. That's how we've done it in the county. So PEARLS is another program I did with Ed Wagner. And if you go to pearlsprogram.org, read about that. That we partnered with with the Aging and Disability Services, area agencies on aging all around the country. And when we did that, we just did our 2 hours. We got a psychiatrist that just did our 2 hours of case review every week. These were county hospitals distributed all over. We had frail older adults that were isolated. We'd go into their homes. And I know exactly what you're talking about from doing that, but we were able to coordinate that and get the case managers to come once a week. We got an hourly psychiatrist, and it really did work. We've been doing it now. We do it in 25 different sites around the country. If you go to pearlsprogram.org, you can see the map of where we're doing it all over. So way over there, and I don't know if the microphone will come to you soon, but if you want to speak loud while we're waiting.
Wondering.
So why don't you start again, because
Yeah.
I think we're
So
recording this as well.
So I work in a health system in Ventura where we have 2 hospitals and 11 outpatient clinics.
Great.
And I think this is something that would be, so I'm a psychiatrist and a primary care doctor. I think this would be awesome for our system.
Cool.
I apologize if you already addressed this, but I'm wondering about why not have the internist who's sitting in on the team meeting? Like, what are the pros and cons to having an outside internist be there solely for the case review versus incorporating the primary care doctors who are actually doing the care and having them be part of that meeting?
Yeah, I'm sure everyone heard that. So there are no real downsides, but if the primary care provider was just only their patients, then that's not very helpful. It's also a second set of eyes. And often the primary care providers can't find that time. You're going to have to find kind of a champion in your organization. So, for example, the cases that I told you about where we're doing with 6 case managers, the case reviewer that's my complement, the internist, he's a PCP, not an endocrinologist, but has stood out for his care of diabetes patients and has won awards and everything. So people really admire him. And I think in the year that we've done this, we've only had one of his patients. All the others, and he just sees everybody else's patients and makes comments and everything. There's no reason why we couldn't see more of his patients, but that's not the point. And it doesn't have to be an outside psychiatrist. It can be someone from amongst yourselves. With psychiatrists, it's easy because we're providing care that we have more experience than most PCPs. But when you pick up another internist or PCP, you have to make sure that they're going to be respected and admired, and somehow they've distinguished themselves a little bit, so that when they make a recommendation. And by the way, the other thing is, that it's not just a recommendation of the internist. When we make a recommendation, it's not Dr. Ciechanowski or Dr. Townsend's recommendation. It's the team care team had this recommendation. Because remember, we have the diabetes educator there. We have the pharmacist who works in a lipid clinic there. We have the other case managers. We're all contributing. And then in the end, we come up with 3 or 4 action steps. That's a summary of our discussion. And then we write it down. Does that make sense? So it's kind of a team, we think of, it's very creative. It's beautiful, actually. It really works. It's like 2 heads is better than 1, 7 heads is much better than 2. And we come up with great, ideas. And not just about adjusting their A1Cs, but about how do we get them back in care? How do we prevent them from falling through the cracks? That's a whole nother part of it, like I said before. Any other questions? I don't know how we're doing for time. We have about 10 minutes left. Yes. Actually, and after that, there's one person over here as well. Yes.
I wonder if you have done any work with patients who have comorbidities, not just a couple of medical issues and maybe a single psychiatric issue, but multiple psychiatric issues, maybe substance abuse, maybe PTSD and depression and diabetes and hypertension, because in the setting that I work, that is my bread and butter. And I'm just wondering if this type of model applies to situations where you really have to be on top of many different things that are going on with the patient.
Absolutely. So are we doing this where I'm rolling this out right now? No. Are other centers around the country starting to do this? Absolutely. They're using brief therapies for substance abuse. They're incorporating that, right? So they're addressing alcohol dependence or addressing opiate dependence. In fact, we here at UCLA, I've been on a grant we're submitting to look at this very question about augmenting this with that. So there's hopefully going to be some actual RCT data as well. But we're also looking at, we address PTSD or, generalized anxiety as well. So you can work out a kind of a stepped care model. So if somebody has depression, but it's complicated by substance abuse, personality, maybe you want to start thinking about including patients with bipolar 2, or maybe even bipolar 1. And if you can kind of think about, okay, we have to have a step care approach here though, because we're asking maybe nurses who they have to be good at, treating diabetes and hypertension, all this, and, bread and butter depression. But once it gets into bipolar illness or mania, then let's step it up and we'll kind of have a mechanism for that. And that's what a lot of groups are doing, is figuring out how to start addressing these other comorbidities. Remember at the beginning I said, I'm just showing you the infrastructure. You can plug and play and interchange conditions, and you may just have to tweak it a little bit for severity. You just want to always make sure that you have the scope of practice available for you and use what we call stepped care. So moving people to that next level for more complexity and having an algorithm to target that, right? And you may want to, again, start out with just what we have here, and then after 3 months or so, okay, now we're going to start including people with PTSD. Now we're going to start including people with psychosis, and then build it from there. Because the trick is the iterative measurement-based care, the treat to target. There was a question over here, I believe.
My question is more logistical around funding and how the various programs that you've implemented in different states,
Right.
in terms of how this is funded. If I'm understanding it correctly, it sounds like it's predominantly consultation for the primary care doctor. So that makes a lot of sense. How does one bill for that? If it's a Medicaid or Medi-Cal system, are you billing for that? How does that infrastructure work?
Every system's going to have to figure out something different. In the group that I'm working, that's a fee-for-service hospital. They worked with payers, and the payers were paying for a complex case management program, and they decided that, this is a very robust way of targeting some of that group, and so that paid for some of the case manager time and so on, so they could bring that in to help pay for it. That's a fee-for-service. Other groups are getting grants. This is like, I think, see where it says team care up there? it says underneath, improving chronic care or improving illness care in the medical home. I mean, this is built for PCMH work. So if you have grants in your regional area or federal grants or whatever for doing patient-centered medical home, that this is a perfect model for addressing, at least 2 chronic medical conditions and 1 behavioral condition, and you can get grants. Believe me, people are getting lots of money to start small projects like this. Over time, the question is how to make it sustainable. Last week, I was in Minnesota, and that was one of our points. There were 8 healthcare organizations there, and we were all sitting together, and everybody came up with different solutions depending on their local opportunities. You have to think of your opportunities locally. So we're having that dialogue with many groups around the country, and you have to think about, where are we going to get the money to support this and make it sustainable. But I will say, when we presented this, at the American Medical Group Association, the CMO of the hospital or the center stood up and he says, look, you don't have to hire new nurse case managers, just train them up, and then just part of the time they're doing this, you've already paid for them, and they're just more efficient targeting these issues, so that's not a huge cost. And then, if you're paying a doc 2.5 hours a week, that's really not a whole lot if you're reviewing 40 to 60 cases and getting accreditation. If you're getting these numbers and impressing people and the funders and the regulations and the policymakers that you're really on board with an ACO kind of system and PCMH, that's money well spent in getting the kind of outcomes you're looking for. So I didn't answer your question because I don't know what the regulations are and where the money pots are in your state or in your city, but everyone has to figure that out to make it sustainable. But there are many creative ways of getting this money. Okay, anyone else? And I can stay afterwards as well. I know it's the end of the day, a long day, and you've got to commute back home. Any other burning questions? Okay, and I'll stay here and answer any. Thank you very much. It was great talking to you.